Yeah, okay, so it's straight up at 12. Okay, so I'm going to start off with some announcements, and then I'm going to introduce today's speaker. Hi, I'm Ed Levin, director of the Duke Center on Addiction and Behavior Change, part of DIBS. And welcome to our seminar series. This is the capstone, the last seminar of the fall 2020 semester. Before I introduce today's speaker, I just want to give a look ahead. We're going to be taking a semester break after this, and then picking back up on January 20th with Becky Klein from the Durham VA and Duke University. She's going to speak about her work with alcohol consumption in animal models and ApoE and TBI, traumatic brain injury, and how they influence alcohol consumption. And then we're going to be picking up later in January circadian rhythms and sleep and effects of alcohol. And then we're going to be going on a twice monthly basis throughout the rest of the semester to the end of April. And then I am starting to actually, believe it or not, starting to put together the seminar series for the fall of 2021. And so if anyone has a desire or has a nomination for someone to give a talk, actually we're not really limited by travel expenses anymore, given that we're going to keep on presumably with this Zoom format. So anyone around the world, and well, if they're on the other side of the world, if they're willing to get up in the middle of the night, that's fine for scheduling for our seminar. So now it's my privilege to introduce my long-term colleague, Dr. Roy Stein, MD, who's a clinical professor of psychiatry at University of North Carolina at Chapel Hill. He's a long-time faculty member in the psychiatry department here at Duke and also at the Durham VA. And Roy is an expert in clinical evaluation of pharmacotherapies and treatment of a variety of different types of drug dependence, and has done a lot of work with ethics and efficacy of outpatient substance abuse, and also policies and practices in medical schools and screening and intervention of substance disorders. Recently took a faculty position at UNC Chapel Hill. And then co-presenting with him is Dr. Robin Jordan, who's on the faculty of the psychiatry department at UNC Chapel Hill. And she's also a psychiatrist and addiction medical specialist, and has developed this hub and spoke model for expanding capacity for addiction treatment in North Carolina. So today they're going to speak to us about expanding access to opioid use disorder treatment, the hub and spoke model. Roy?
Thank you, Ed. It's a pleasure to be back virtually. So yeah, we're going to talk about the issue of access to opioid use disorder treatment. We have no commercial disclosures or conflicts, and these are the sponsors that are supporting the UNC initiative that Robin will be talking about. Oops. And I think you know who you are in the audience. And we're hoping that you'll have a better sense at the end of the status of the opioid epidemic in North Carolina, a sense of the effective treatments that are available for opioid use disorder, and really focus on this whole issue of implementation, how to get the effective treatments to the patients who need them, and focusing on the hub and spoke model that we are in the process of adapting and developing in North Carolina. I think just about everybody who's dialing into this is well aware that we have a very serious opioid use disorder problem in the United States, exemplified by the sharply rising overdose deaths associated with opioids. And since about 2013, this has really been driven by the increased use of the synthetic opioids, specifically fentanyl and fentanyl analogs, whereas some of the other causes of opioid-related death have actually leveled out. Now, just keep in mind that deaths are just one very severe and grave marker of the impact of the opioid use disorder epidemic, because of course, there's tremendous impact from infectious complications, infective endocarditis, resulting in very costly, elaborate, and lengthy hospitalizations for valve replacement, increased transmission of Hep C. And of course, there's tremendous just human costs in general. So the it's easy to track, or easier to track and look at graphs of opioid deaths, but there's way more to the picture than that. And for a while in the, like, say, 2016, 2017, this was getting a tremendous amount of attention in the media. And in October of 2017, the president, there was this declared an emergency, but requested no new funds. In October of 2018, Congress passed the Support Act, which is really one of the very few bipartisan pieces of legislation that come through in the last couple of years, which focused on a lot of things more on the interdiction side, but it did expand Medicaid to require Medicaid to cover all FDA-approved medications for opioid use disorder, which is a pretty significant step forward. And it also authorizes Medicare to cover services from opiate treatment programs, i.e. methadone maintenance programs. So it did provide some expansion of treatment. However, and so actually in 2018, there was a heavily touted dip in opioid overdose deaths of about 5%, and people suggest, oh, maybe we're making progress. And you can see that was this dip up here under the any opioid, but unfortunately you see that the synthetic opioid related deaths, the fentanyl deaths, continue to increase, while some of the heroin and prescription opioid deaths dipped a bit. It's interesting that the CDC never updated this to show what happened in 2019, because in 2019, the deaths, the decrease that we saw the previous year was completely erased. And in fact, the deaths from opioid overdose have continued to rise in 2020. This is a different graphic that I was able to get from CDC's website that does show up here to the upper right. There was this sort of flattening or slight dip, and then an increase that takes you into early 2020. And again, driven by the fentanyl and fentanyl analogs. So just last month, October of 2020, the American Medical Association put out this issue brief pointing out that more than 40 states have reported increases in opioid-related mortality during the pandemic. So we can expect that the 2020 figures, when they become available nationally, are only going to be that much more concerning. Now, at the same time that this is all going on, I think everybody listening to this knows that we do have effective medications for opioid use disorder. These are not cures, but we have 4 different approved medications, all of which have demonstrated benefits. And particularly, of course, the ones that have been around the longest, methadone and sublingual buprenorphine, have been shown to reduce opioid deaths, reduce, in the case of methadone, reduce HIV seroconversion. Buprenorphine has been shown to reduce opioid use, Hep C and HIV risk behaviors, and improve risk treatment retention. So these opioid use disorder is a chronic disease, and we do not have cures for it, but we do have treatments that alter the course and that do save lives. So that's, yes, that's encouraging. So if things were working in a sort of idealized world, we would have the preclinical research that we heard about, for example, 2 weeks ago from Dr. Comer, work that people like Ed Levin are doing. So preclinical research ultimately leading to efficacy studies that under tightly controlled situation demonstrate that the drug works. And then if everything is happening ideally, then this leads to the drug or the treatment is used and we see improved public health. Unfortunately, a very small fraction of the individuals who are potential patients, in other words, people with OUD, only a very small fraction of them receive effective treatment. And Williams and Nunes at Columbia and colleagues recently reported that of the slightly more than 2 million persons with OUD in the United States, only 20% receive any kind of treatment. And of those who receive treatment services, only 1/3 receive any of the effective medications. So that's a pretty disappointing figure. And the retention, once you do get people into treatment in a given treatment episode, is about 30 to 50%. So there's a very high dropout rate even once people start. And it's estimated that only 2% of Americans with OUD achieve long-term remission. So kind of a dismal number. So this is where, and you'll forgive this cheesy graphic, I would suggest that our pipeline from efficacious drugs to improving public health is leaky at best. So this brings us to this notion of implementation science, which is getting attention and is being used in a number of different areas of medicine. This is from the National Cancer Institute website, which defines implementation science as the study of methods to promote the adoption and integration of evidence-based practices into routine healthcare and public health settings to improve population health. Bauer and Kirchner wrote, and I'll just mention Bauer is at the Boston VA's Center for Healthcare Organization and Implementation Research. So he's associated with the VA Center and with Harvard Medical School. Kirchner is with the VA Health Services Research and Development Center in Arkansas. So they have written that implementation science seeks to, quote, continue the job of biomedical research, taking evidence-based innovations into wider practice. And in particular, it focuses on the context in which clinical innovations are used, not just the treatment itself, but how does it actually, what are all the factors around the treatment that actually influence what happens? And they're interested, of course, in breaking down the research practice divide so that researchers actually need to interact and partner with healthcare leadership and staff to bring about public health improvements. So this is kind of Bauer and Kirchner's a more sophisticated depiction of the pipeline. So we start with preclinical research and the efficacy studies, which of course are in very tightly controlled situations, to effectiveness studies, which are using the treatment in more real world settings, but still focused on just treatment outcomes. And then we move into implementation research, which looks at the whole complex of factors surrounding the delivery of treatment to both identify the barriers and the facilitators to bring about the improvements that are desired in public health. So that can include both observational studies as well as carefully designed implementation trials. I would tend to say that what Robin will be talking about is more in the observational mode right now, but you can comment more on that when you're presenting the data. So this is just, and there are federal funds at all of these different levels to support the different types of research, the NIH T1, T2, and T3. So, given that implementation science is very concerned about the context of a treatment actually getting to the people that need it, I put together this slide to illustrate, certainly not an absolutely inclusive, but at least some of the factors to think about that might affect, are people getting the treatment? So if you start with the person with OUD, there's the issue, are they motivated? And of course, coming from an MI perspective as I do, motivation is dynamic and fluctuates, and we assume that people are ambivalent. But in any event, people's level of motivation varies, and some people are not that interested in stopping drug use. I mean, that's a fact. But also people's motivation may be affected by stigma and fear of being labeled, fear of being identified if they come forth and say they have a problem and they accept treatment, that's going to become more open, and they're afraid of being judged and rejected and mistreated. But there are other factors. Do they know about the effective treatments that they could get? Do they have access, which is a huge problem? And then there are family and community factors that may influence their seeking treatment. On the provider side, we have a very similar, I think, conflict between the motivation that many healthcare providers have to address a very serious human problem and a public health problem, wanting to do something about it, versus a stigma and fear of not wanting to be associated with this, not wanting these patients in my practice, not wanting to get all involved with this. I just don't want to be part of it. So there's a motivation issue there. There's training. Now, in the case of buprenorphine, waiver training to get the X waiver is widely available with very large initiatives. So it's available online, it's free, you can do it on your own time, it's being incorporated into medical education. So there are a lot of progress is being made on getting people trained, but the clinicians still, even if trained, may not have the confidence in actually applying it. And they may have issues of, do they have the time and do they have support staff to actually implement it in their practices? There's also the issue of the recovery community, which certainly could be a positive force, and in some cases is, but in other cases, many people in the recovery community are not in support of any kind of medications for addiction treatment, which I think is very unfortunate, but it's true. And just to give you a quick anecdote, I now actually have 2 patients. I'm working with 2 young women, both with severe addiction disorders, both doing well on Suboxone, but they need residential treatment to address their other cocaine use disorder or other problems besides the opioid issue. Both of them, in order to enter long-term residential treatment programs, are having to be tapered off of Suboxone. So that has to do with attitudes in the recovery community, program policies, and that to me is really, really disappointing, that I have to take somebody off of an effective treatment, potentially life-saving treatment, so they can engage in more intensive residential treatment. Seems crazy. Public policy, of course, laws and regulations surrounding the prescribing of the drugs that we're talking about, and of course, payment systems are a huge issue. And then at the healthcare system level, there's financing, of course, but also, even if you have providers that want to provide the treatment, people who want to get it, is the system providing the facilities and staffing and support to make that possible? So with that backdrop, I wanted to just spend the remaining part of my time sharing with you the Vermont experience, which really has become a model for the nation, and which in many ways we in North Carolina have been learning from and trying to adapt to our situation. Well, Vermont realized in the early 2010s that they had a very severe opioid use disorder problem. There were ex-waivered physicians in the state. By the way, now it includes MDs, PAs, and NPs, but at that time it was MDs only. But there were ex-waivered physicians, but most of them had few or no patients receiving so-called office-based opioid treatment. So they had a waiver, but they weren't using it to any significant extent. There were very long wait lists. People were dying of overdose, but there were long wait lists for treatment. And state leadership recognized there was a need for specialized clinics that could get people started on Suboxone, transfer them to ongoing office-based care in the community, hang on to the complex patients, and receive.
All right. So Roy was talking about the Vermont model, but I think if he's able to come back, we can have him kind of wrap up on the Vermont model. And he was talking about how hub and spoke models are being able to be used now across the country. Vermont and California also has a really good hub and spoke system. And so then we're going to transition over to me with talking about what we've done at UNC. And I joined faculty in 2016, and this is what I still feel like this is my life. This is what I felt like whenever I joined faculty. So all the little blue faces in here, these are all the faces that want treatment but can't get it. And then the little yellow face is the one person that gets through to our clinic and that we're able to treat. And you know, my goal here is that we don't have all these blue faces. And so I set forth to figure out how can we work on expanding capacity for addiction treatment using these implementation science that Roy was mentioning. And so I'll put this up briefly just to show the timeline, and that our emphasis is on multiple areas with our clinical service and education and research. And I'll show how that the hub and spoke is the glue of a lot of this. And so when we started the clinic, it really was just me and some residents. That was the addiction program that UNC had. And over a short amount of time, we've been able to bring in more people. We've got a project manager and peer supports where we started. But when we were able to co-locate our medicine clinic with our therapy clinic, that was a huge transition for us, being able to have medicine and therapy in one location for the first time at UNC. And we've been able to bring on more people onto the team and make some good partnerships. And in 2018 is when we started our addiction medicine fellowship. And that's progressed over the last couple of years. We got ACGME accreditation, and we brought in social work into the training and brought in, right now we're training a PA fellow. And in January, well, I think we're going to have a nurse practitioner fellow. And then this year we got an award from HRSA to expand our fellowship. So now we can train up to 8 fellows a year, and we're in the process of recruiting for that right now. But that's certainly one way of expanding capacity by having the trainees on site, but that obviously expands the workforce as well. But the big thing we started focusing on was this hub and spoke model. And I could see that I had a clinic full of patients who were pretty much stable on buprenorphine and uninsured. And because we had so many patients in the clinic, I couldn't take on new patients. And I saw that as a really big problem. So I started out with this partnership with Piedmont is a federally qualified healthcare center. Piedmont serves our area around Chapel Hill, several counties around us. And so this hub and spoke model really just started with a partnership between their medical director and me. They wanted to build their buprenorphine program, and I needed a partner who would take stable patients. And that's how we got started. And July of 18 is whenever I said we're formalizing the start of this hub and spoke model. And that first year, we had 42 new patient evaluations. And I really wanted to get the number, what we had before then. It's just not final, so I didn't want to show it, but it's going to be somewhere around 15 or 20 patients of new evals that we had prior to that. But then year 2, we had 105 new patient evaluations. And that's just from implementing this hub and spoke model. And then that has allowed us, by putting this hub and spoke together, it has allowed us to do additional things. Like we were able to bring a project to the emergency room of bringing buprenorphine and peer support into the ED at UNC. And now this year, we're doing a similar type of project in the hospital and engaging people directly in the hospital and getting them connected to addiction treatment. So all of these things really kind of play on each other, but have allowed us to make some advancements in expanding capacity for addiction treatment. And so we started looking at our clinic. Our clinic is a STAR clinic, so it's substance treatment and recovery clinic, more as a transition clinic, a temporary time that people come and stay with us rather than they stay with us long term. And so the idea is that we want to take people, the little blue boxes, these are just examples, but taking people out of inpatient sources. We always will have our outpatient referrals that we take people from, but that they come to us, I say ideally for 4 to 12 weeks. They stay with us longer than that, but the goal is that they don't stay with us too long. And once they're stabilized, we move them to outpatient places where they can stay for their longer term maintenance treatment. And at any time, if they destabilize, they can always come back. And we reprioritize, as I have over here, like from Piedmont, we prioritize any of our spokes sending patients back to us. We get them in as quickly as we can. So we started out here in 2018 with just our little STAR clinic, and with Piedmont, that's where our hub and spoke primarily consisted of. And as I said, that first year we took 42 new evaluations. And what was important to me, what really stood out, was that 28% of those new patient evals came from inpatient sources. And prior to that, it was 0%. Prior to us really formalizing this hub and spoke model, we couldn't take people out of inpatient sources. And people from the inpatient sources, we know that people coming out of the emergency room, people coming out of the hospital, that they're at a significantly increased risk of overdose death. And so we really want to target those patients and get them connected to treatment. So we could see very early on that this hub and spoke model was a way for us to increase capacity for those at highest need. And then I just have here some of the places that we have to have a lot of spokes to refer our patients to. So this just depicts the kind of places we're referring our patients to. And so over the last couple of years, our clinic has developed, we really want to emphasize the multidisciplinary approach. So we have our psychiatrists and therapists, we have pharmacists that work with, I say pharmacy, but pharmacists who are a team with us, and our peer support specialists and case managers. So they're a part of our team. My goal is to get primary care, pain management, supported employment on site with us. We were making progress toward that. Nothing is on site anymore, but we've got good partnerships with primary care and pain management right now. And then our clinic is not very big. So the clinic is, we have one PA who's part-time and then 1.5 psychiatrists. That's Roy and me. And then we have some LCSWs for the therapy component, our fellows, peer support specialists, and a project manager and our care managers. So it's not a very large provider base that we have. We really do emphasize a lot on training as well. And we not only have our own addiction fellows, but we've got rotations for pain fellows, palliative care, infectious disease. We have residents from many different specialties who are now doing rotations with us. And then APPs, as I mentioned, we've got a PA now. We're about to have an NP in January. We have pharmacy residents that are training with us in a formalized program with social work. So it's very, very important to us that we get multiple disciplines together and that we're all training and learning together. So I have our data from, I'm calling this year 3, year to date. We're developing a database right now and getting all of our data into the database. So I just didn't have it organized enough to show you year 2, but I can at least show you from July to today. And so from July to today, we've had 51 new patient evaluations. And what's really stands out to me is that 70% of those intakes come from inpatient sources. So in just this 2-year period, we've been able to go from 0 patients from inpatient to 28% that came from inpatient sources to now 70% coming from inpatient sources. And I don't know what the goal, I don't really have a goal of how many patients we take from inpatient, but I know it needs to be more than 30%. And we'll always take some from the community, but I'm really glad we're able to take them now out of the hospital and out of the emergency room. And the 42 new evals we did in year 1, this is 51 new evals in a 4-month period. So, I'm thinking we're probably going to be somewhere around 150 to 200 patients that will have taken new patient evals this year, during this academic year. And these are the spokes that we've developed now over the last couple of years. So it started out with just this little spoke with Piedmont and us, and now we have multiple FQHCs that we've got formal partnerships with, and then other clinics that we've formalized as our spoke. And Mayhack out in Asheville, we've got a partnership with them, and they're now a part of this hub and spoke model with Mayhack serving as a hub for the western part of the state. So the goal is that we're going to expand this hub and spoke model more statewide, and ideally we find a site that could serve as a hub in the east. We're not quite there yet. And so thinking about this hub and spoke model and how that has helped us improve capacity, I wanted to just take a few minutes to talk about the work that we've done in the emergency room and the work that we've done in the hospital, and show you how that hub and spoke model has been able to have an impact for us with improving capacity. So we know that data has shown if you given a person in the emergency room buprenorphine and a referral, they're 78% more likely to attend that program versus a referral alone or versus just brief intervention and a referral. But giving the medication in the emergency room plus connecting to the treatment is what's successful. And so we were asked to bring a project into our emergency room that did that. And we decided to use this SBIRT approach, which is screening, brief intervention, and referral to treatment. And we used our peer support specialist to do the screening in the emergency room. And I don't know if any of y'all have any questions around that. That was a very interesting endeavor to try to get a screening process in the emergency room. But we had our peers do the screening and do a brief intervention with the patient and then refer to treatment. A lot of the patients ended up wanting to come to our clinic because they were uninsured. And so just show you briefly, over a 6-month period, our one peer was able to screen almost 1,200 patients. And he was screening door to door. So there was no preference on who he was screening. 260 patients that he screened positive for substance misuse. So that's about 22% of the patients that were screened positive. And then 40% of those patients who screened positive requested treatment, which I thought was a pretty big deal that so many patients would request treatment. And then if you think about those who request treatment versus those that were screened, 9% of the patients who were screened ended up requesting treatment. And so these are patients that would likely not have been offered treatment otherwise. These were patients identified because of the screening process. And so what are they screen positive for? A large part screen positive for alcohol, which is not surprising. Marijuana was on the screen, and we're using a validated screen, so that was left on there. But then you see this, chunk of other substance use that people screen positive for. And what I think is most meaningful is that we looked at the patients of those who screened positive. What percent of those patients requested treatment? And so we looked at the heroin patients. So of those heroin patients who screened positive, 94% of those patients requested treatment. And then when you look at prescribed opioids and cocaine, it's about 80% of those patients who were screened positive requested treatment. And I went back to our peer and I asked him, I said, what's the deal with this 6%? Why didn't they want treatment? Like, what was their deal? And it was only 3 or 4 patients. I don't remember exactly. It was a small number, but he said that the ones that didn't want treatment, they all gave a similar story. I was in a program and the funding got cut and I lost treatment. I can't afford it and I'm tired of the, in and out of treatment, and I'm tired of it. And it all came down to they weren't able to access or afford treatment. And so what this says to me, at least, is, this is we have to keep in mind the population who this is. These are people who come to the medical center, who come to the emergency room. They're coming not just for substance use, they're coming for other medical problems. But those who have heroin use, who come to the medical center, want treatment. So there's pretty good likelihood if you see somebody, reaching out to a medical person and they have heroin use, very good likelihood that person actually does want treatment. And then it was just surprising to me as well, seeing how high those with problems with cocaine and opioids, that they're also requesting treatment. And then one day when we have more time, 40% of the patients who screen positive for alcohol request treatment, which to me is also surprising, how many people want treatment but don't have access to it. So that's a story, I think, for another day. So a lot of these patients, where did they go? And Roy was just mentioning office-based opioid treatment. So this is the acronym we're supposed to use, but this just basically means outpatient clinic. So for those patients who screen positive for opioid use, majority of those patients wanted to go to outpatient treatment, and we were able to connect them to outpatient treatment. And this coincides with our first year of being a formalized hub and spoke model. And so this is our little pie slice where we took people from the emergency rooms. The first time we were ever able to do that. And because we couldn't have been successful in our emergency room project had we not had this hub and spoke system set up where we could be able to take the patients and then refer them back out. And so the other piece of this is looking on the inpatient side. So we got this set up on in the emergency room, and the state funded this for us. And the state came back and said, we'd like to see something similar on the hospital side. And so it's the same story for the hospital. This is just older data that people in the hospital, people are hospitalized with opioid use disorder, if they're either linked to buprenorphine with linkage to treatment, either that or they're given a 5-day buprenorphine taper. So how many of those patients successfully enter treatment? So obviously the ones given buprenorphine with linkage to treatment, a large percentage of those actually get connected to their outpatient treatment program. So it really shows the need of getting people medicine in the hospital and getting them connected to treatment. And so what we were funded to do starting January 1st was to connect with patients who are hospitalized with infections from IV drug use. So it's a pretty specific population, and it's really targeting the endocarditis patients. But we found that osteomyelitis was another large subset of this population. And then the other is various abscesses that people might have that don't necessarily turn into endocarditis or osteomyelitis. But those are the patients that we've targeted with this project. And their distribution, the bulk of them, 90% are 45 years or younger. what we have been consulted on, they're 96% white, 69%, 70% female. This has been 70-30 pretty much the whole time. And so basically what this is young white women that we're consulted on. There's obviously a whole lot to understand around why that is, and we're still learning why that is. We have a lot of theories, but not a lot of answers of why this is the population. But largely for these people who have endocarditis in the hospital, this is what the distribution is. It's young white women. And so where do these patients come from? So UNC takes patients from all over the state. If somebody gets endocarditis, they end up coming often to UNC to get evaluated for heart surgery. And so for the patients that we've connected with, this is where they come from. And so these in the blue, we've had more patients from these counties. And then Lee County, we've had a lot of patients. This is Stanford. We've had a lot of patients in this area. I don't know why. I've been calling this the opioid belt because we get so many patients from this area. And I don't know why. I don't know what it is yet about this particular area. There's not an interstate running through this area. So I'm not sure why that's where such a large population is coming from. But it appears to be. And so when we started this project, we were looking at where the patients were going when they left treatment. Were they getting connected to outpatient treatment? Were they getting connected to a OTP, which is a where they get methadone daily dosing or buprenorphine daily dosing, or were they not connected to treatment at all? You see, COVID hit, so April, May, June, we weren't able to be in the hospital and we weren't able to connect with as many patients. But regardless, from when we started January, February, March to now, we're getting more and more people connected to outpatient treatment. And this are my last data slide here. One of the metrics that we're following is hospital readmission rates. And so we're looking at patients. We'll follow them 30, 60, 90 days and out to 6 months is a total that we'll follow. And so what I have here is, so far we have enough data for 30-day and 60-day to show you. And for the 30-day, those patients that were connected to Star Clinic, which is us, is about a 6% readmission rate compared to those patients that were not connected to our clinic, which is about close to 29%, 30% readmission rate. And so we've had enough data each month starting in August. So this is our third month in of being able to collect 30-day data. And that trend has stayed the same. October was our first month to be able to have enough patients that fall in the 60-day category. So that's our first round of 60-day data. It's about 30 patients in that category. And so you see about 23% of those connected to our clinic have had readmissions, hospital readmissions, compared to 83% for patients not connected to our clinic. So this is very encouraging to us that if we can get patients connected to outpatient treatment with buprenorphine, that they're going to go to the hospital less. And a large fraction of these patients are the patients with endocarditis that have the heart valve replacement. So really important to be able to keep those patients home and out of the hospital. And so we'll come back here to where we started at this idea of not having enough capacity for treatment. And we're still here. I said this when we started. I still feel like this is my life. But my goal is that we end up here, that we continue this mission until no one is turned away from addiction treatment, that everyone gets access to life-saving medicine. So that's kind of where we'll wrap up here. I put this number in here, and Roy didn't mention this, but for North Carolina, there's been a 24% increase in ED visits for opioid overdose, 24% increase compared to this time last year. And this seems to be about what it is across the country. It seems like there's around this 20% increase nationwide. And North Carolina's had this increase each month now, August, September, October. There's been this overall 24% increase. So I say August when we really had the 24%, but the increase started in April. So it's clearly the increase occurred after COVID started. But we do have effective medicines to treat opioid use disorder, and but many patients still in North Carolina and across the country continue to have difficulty accessing treatment. And so we talked about the hub and spoke model and how that is a way that's helping expand capacity for treatment. And it allows us to not just have more patients, but allows us to really focus on who we're taking patients from and taking patients at the highest risk of overdose death. And so what's not listed here is taking people out of the judicial system, which is a huge goal. And we've had a few patients that have come directly out of prison, but we don't have a formalized referral process from them yet. But that's definitely future direction for us. And we have to continue to expand our ability to be able to take them out of the prison system. But that is where I will stop. And
I'll just say I'm back.
Oh,
Yeah.
great.
So Roy, do you have some other things you want to say?
I just want to make a couple of points very briefly. I think the internet gods wanted to intervene and make sure that Robin had plenty of time, so they took me offline for a little while, but I'm back. So yeah, I just want to make a couple of brief points about Vermont, and then we'll open it up for discussion. So this is, I think, where we left off. So really, I mean, I think Robin has very well explained the hub and spoke concept. And I think I just want to highlight some of the particular advantages they had in Vermont over, and just also to say that it is absolutely remarkable what Robin has accomplished. I mean, certainly there's been a lot of collaboration, but she's been kind of the one person driving force to make all this happen. And it's, you know, really a privilege to be working with her. But in Vermont, they decided to create these 5 hubs, each with a set of spokes. And the spokes would be any ex-waivered physician. At that time, it was only physicians. They could be at an FQHC, they could be in a private practice, they could be in a hospital-based practice, they could be internal medicine, family medicine, OBGYN, psychiatrist. So it was very open to any physician who was willing, and physician or clinic or setting that wanted to be involved. And what's a distinct difference is that in this model, if you were a spoke, they allocated 1 RN and 1 master's level behavioral specialist per 100 Medicaid patients. So if you were a big practice with if you had 100 Medicaid patients on OBOT, you would get both of those people full time. Whereas if you were a smaller practice with fewer of these patients, you would share such a team across several practices. But the point is, they, at a statewide level, allocated these 2 FTE important support positions per 100 Medicaid patients. Now, the key thing there is this whole project, this whole thing was financed through Affordable Care Act Medicaid expansion funds. So that's the huge difference, is that we don't have that here. And, you know, I mentioned earlier that the Support Act in 2018 mandated that Medicaid pays for FDA-approved OUD medications. But if people can't get on Medicaid, they can't get that benefit. So that's just a huge public policy contextual impact on what's happening to the people in our state. And so then just to shift over to some of the, after 4 years of implementation, Brooklyn and Sigmund reported the first 4 years of the Vermont model, they had a dramatic increase in OUD treatment capacity and enrollment. They went from being one of the lowest per capita treatment enrollments in MAT to being the highest state in the country of people getting treatment for medication-assisted treatment. There was a 64% increase in waivered physicians and a 50% increase in patients served per waivered MD. So people were getting their waivers and they were using them. There was robust bidirectional transfer of patients, you know, between the hubs and the spokes. And an important point is that on a cost analysis, it was either neutral or there was a modest net savings in healthcare costs, even when including the cost of OUD treatment. In other words, this, in addition to saving lives, although they don't have mortality data, but in addition to treating people and presumably saving lives, they actually broke even or saved money because, you know, one endocarditis valve replacement admission pays for a hell of a lot of outpatient treatment. So given the success of this model, It's been adapted. Robin is working on it in North Carolina, but it's been adapted at a statewide level in New Hampshire, California, and Washington. So that's just to give a little bit more of how things went when there was the full-throated state level commitment, to cover the whole state, but it also required Medicaid expansion to make it happen. But it was effective and it was cost effective. So those are the only other points I wanted to add. So now I think, Robin, any other comments before we take questions?
No, that's good. And welcome back.
Yeah.
One other thing is, once you get this model going and with the hubs and the spokes, once physicians and other prescribers get a little experience with Suboxone, they realize it's not such a big deal. It's not this scary, weird thing, and life isn't going to go out of control. So once you have a model that supports people to get involved, they do, and then they see that, hey, this actually is helping people and I can handle it. And then it grows through kind of social contact.
Well, I wanted to thank you guys, and you handled it very nicely, especially with the technical glitches. But I congratulate you both in terms of setting this up, and this hub and spoke model seems to be really working quite well. So we do have some time for discussion, and if anyone has a comment, please unmute yourself and then speak up. I had a question. Roy, you talked about the Medicaid expansion and the problem of that not being enforced here. I wonder, in terms of private entities, like Blue Cross Blue Shield, other insurance companies, you guys rightly showed that. I mean, as awful as the mortality rates are, the morbidity rates are more considerable. And if a medical economist gets in there and could show that there would be considerable cost savings if we can short circuit some of these endocarditis and other medical issues that would come up if we could adequately treat the substance abuse disorder before it came to that emergency.
My understanding is there a possibility of
that?
I believe that, and Robin, I want Robin to comment. I believe that most major private health insurance does cover medication-assisted treatment for opioid use disorder. Now, how much they cover, and there's all kinds of wrinkles to that, but in general, most of them do provide coverage. Robin, would you?
Oh yeah, it's gotten a lot better, because it used to be even like Blue Cross would cover, but somebody's copay might be $150, or that would be like their copay for the medicine. Like, it was outrageous. They just barely covered. And then there are all the prior auths that we had to do that would get denied and denied, but all that's gone. So we don't have to worry about any of that anymore. We just prescribe it and it gets covered, and people's copays are normal, like whatever their normal medicine copays would be, normal treatment copays. So that part they've gotten on board. But I'd like to add that UNC's average cost for taking care of somebody with tricuspid valve endocarditis that needs a heart valve replacement is $275,000 for one average cost. And from 2018 to 19, over the 2-year period, it was estimated UNC spent $6.8 million on 25 patients with tricuspid valve endocarditis. So it's and 60% of these patients we know are uninsured. So it's an extremely expensive problem that the university is now listening. So we started this conversation with them about 3 or 4 years ago, and it was actually this week, Monday, that I was able to present it. They requested an application to them for how to formalize and fund an addiction program for UNC. So I don't know yet what they're going to do, but they requested that we submit this because they recognize the endocarditis problem is a real expense and needs to, we need to do something for that.
Yeah, and ever since we've started the consult, the inpatient consult started only since I started at UNC in April, and the consult started in July, and every week there are new patients with endocarditis. I mean, it's a steady flow. This is not a rare event. I would say there are always several people in the hospital, and many of them there for a long time. Many of them with repeat heart surgeries. It's incredibly damaging and they're young. It's heartbreaking to see personally at a human level these 23, 25, 27-year-olds
Yeah.
with this degree of disease. But there are a lot of them. And so, yeah, the cost impact is phenomenal.
Right.
This is Cindy. I have a quick question before we go to APT. Were you able to recruit so many additional people from within UNC? Because you had multiple departments, which because the key to this working is having lots of spokes. And by the way, this was great. It was really interesting, and thanks for doing it. And I've read about the endocarditis thing, so it's really important because they come back and back and back and back. But what did you do at UNC that was so successful?
I think there's two aspects of that. That's one within UNC and one of the spokes outside of UNC. And within UNC, it's people want to participate. People don't like that their patients are facing this problem and don't know what to do about it. So that part's been easy. So linking in the education piece where we can bring people in as training is where we've been able to get the multidisciplinary work. And then that's great because it brings the attendings together, and that's where it's also just a lot of fun. On the spoke side, what I learned very early on with that first relationship with Piedmont was whenever I show up face to face and say, I'm your person, if you need help, I'm the one you call. Here's my cell phone number. You can always send them back. If this doesn't work, I'll always take them back. That has worked. And so that's what we've done with all the spokes I've interacted with. They've got my cell number. They can call me, text me anytime. And that seems to give them that confidence of like, okay, this is okay. And so then we kind of work with them and provide education and other resources to help them build their program. But I think it really requires that face-to-face, one-on-one mentorship to get them on board and feel comfortable.
Well, thanks a bunch. I got to run, go give somebody a lifelong job at Duke. So here's hoping, but thank you. That was really interesting.
Okay, great. Other questions?
Yeah, I've got one. So I'm curious about the transition from the emergency department into your clinic, because we at Duke have set up peer support specialists availability. They're not resident in the emergency department, but we've struggled to really perfect, and we've been working over the past few years to perfect this idea of a warm handoff. So how do you guys just do it in practical reality?
It was a massive undertaking. It was about 6 months of preparation before we launched our peers being in the ED, and then probably 9 months total before we had our first buprenorphine induction. And the social workers were really the key. So we had to have a very good relationship with the social workers. And we had the peers in there where the peers, the ED people started to realize who the peers are and started to trust the peers. Then the peers could go to the docs and say, hey, this one's got OUD and wants treatment. And then the peer goes to the social worker and say, hey, this one wants treatment. And then we've got a protocol with the social workers for anybody wanting treatment. It's just an instant automated message to us. And then it's an automated acceptance for us, whether we have room or not. We have to sometimes figure that out, but that's what we do. And we don't have peers in our ED anymore. This is just a sad thing that has occurred. But that system is in place now. And so we continue to get referrals from the ED where they're able to start it. And then we see them. And we guarantee that we'll see them within 7 days, which I think also helps.
Yeah, I would just highlight, I think Robin mentioned, but the ED there is starting on Suboxone and referring them to us. Mm-hmm. So, and we see them within days, literally within single-digit days.
So it sounds like you really built trust with the ED personnel, and now they trust you.
Yes, it was a lot of relationship building. And now the relationship is there. It's very good, but yeah, it was some work. There's a question that
we do need to be able to we're a hub, but we're also a bridge, because we do have to move people out so that we maintain this capacity to take the incoming referrals from the ED in the hospital.
Sure.
I see this question in the chat, so I'll make sure I address that. The question is, can you please explain how endocarditis is related to opioid use disorder? So it's from IV injection drug use. And so with IV injection drug use, you'll get bacteria that's introduced into the skin. And the bacteria likes to stick on heart valves. And so that's when you get the infective endocarditis. It also likes to stick in lungs. And so you get septic emboli. And then they stick anywhere there's small vessels. We've seen recent 2 renal abscesses from infection drug use. But the endocarditis is, well, endocarditis and I think it's septic emboli are probably the 2 most common that we see.
Okay, we have other questions. We have a couple more minutes.
I have a comment and a question. This is Larry Greenblatt. Hello to Robin and Roy. Good to see you both. So my comment, Medicaid becomes a prepaid program starting in July. The state is prepaying the insurers who are there. That's why we're calling them PHPs. They're not prepaying healthcare providers, but they will be very interested in reducing their costs of hospitalization for endocarditis and the like. I'm sure of it. One of the PHPs approached us. This was when we thought we were going to do transformation, like a couple of rounds ago, wanting to create basically an incentive system, value-based care for people with OUD, and a provider would get a certain amount of money for enrolling a patient, for doing proper screening, for keeping them enrolled. There would be additional monies, et cetera. So I don't know if the state's going to allow them to do that kind of thing, but they're willing to invest in making sure that there's adequate infrastructure to try to reduce, both the admissions and readmissions, which are going to be a major expense. So here's my question. My question is, this is a really radical one. Would the UNC hub take a referral from a Duke provider?
We already do.
Yeah.
Yeah. So the ED, I think y'all started seeing ED patients this summer, maybe. But we started getting referrals from the Duke ED a couple months or so ago, and we'll gladly take referrals from you guys. Now, let me forward this with saying we prioritize people at highest risk of overdose death. Now, I don't like that, right? Like we want all yellow faces, but that's what we prioritize. And so certainly out of the hospital, out of the ED, we're going to take them. Out of the outpatient community, we're going to see if they have a high enough need. And if not, we'll give you recommendations of where else they could possibly go.
Yeah, I'm specifically thinking about providers who are doing buprenorphine care where they have a patient who is not doing well, because we really don't have any kind of resource now. Any other disease that I treat in my practice, there's someone I can refer to, whether it be a psychiatrist for refractory depression or a cardiologist for worsening heart failure. But if one of my OUD patients is doing badly, kind of don't have anybody, and that's a fear for a lot of the primary care clinicians who want to do this. Where can I send my patient when I need it?
Let's talk specifically, Larry, because I'm happy to help with that. I mean, our deal is that you just got to be willing to take them back. Right? We can't get stuck with them, but as long as you're willing to take them back, then we are happy to take them and stabilize.
Okay. Yeah.
I would just comment that, one of my recent referrals is somebody who was hospitalized at Duke after a massive fentanyl overdose it was not readily reversed with the usual amounts of naloxone. And so she's in our program now. And I would just put in a plug, I'll just say it, having come from Duke and still having Duke ties, I encourage everybody who's concerned about this to make noise over there, that, particularly directed at the psychiatry department. That's where I come from, to take this seriously, and from the health system level to take this seriously, because it's been disappointing that much as UNC now we want to help from our end, that Larry doesn't have that support within such a world-class institution.
Well, psychiatry certainly could do more. I'm not sure they could do less. They're doing almost nothing around OUD.
Right.
Well, I'm well aware of that. That's why I'm where I am. Right?
Yes, we'll take that under advisement. Thank you. Well, thank you, Robin. Thank you, Roy. This has been a great presentation and a wonderful program, the Spoken and Hub model. And wanted to thank everyone for the great discussion. If you have further questions, their emails for Roy and Robin are on the CABC seminar list. And so now I see it's right at 1. I wanted to invite everyone to come back on January 20th. Actually, I think it's right at the same time at noon that we'll be swearing in a new president. But please come for our CABC seminar, and we'll be going on twice monthly basis. And if you have a desire to present or someone you would like to see present, feel free to get in touch with me. edlevin@duke.edu is my email address. And thanks again for everyone, and have a great day.